John. Thank you, Margaret. Yes, the recording did stop, but I got it going again. All right, we've got a quorum.
Next issue is to review and approve minutes from the December 2022 meeting.
Correct. Someone have does everybody have copy? Okay.
Any motion? I'd be willing to entertain a motion to approve.
I'm not really hearing Scott. I don't know if his microphone isn't on or something.
Let me see if I can turn up the owl. We might it just might be your mask, Scott. So
yeah, Scott, if you're looking for a motion to approve the minutes, I'll make it.
How's the audio now, Matt? Still not good?
Nope, still can't hear you.
okay, we'll work on that.
Did you hear Kara okay? Would it be better if I shifted around to the side maybe?
I'm doing all the buttons that I can find with sound, so.
Yeah, I mean, we can hear Kara fine.
Okay, so maybe Scott needs to come sit next to me. He was trying to spread around the table. So. Right, yeah, don't forget your coffee.
Okay, how's that? Okay, great. Any better?
Not really.
It might
Slightly.
be. I'm working on it. Just a second. Thank you for your patience. Okay, now can you hear Scott? Sorry, Scott.
Okay, testing. Much better. Okay.
Much better.
Sorry, we have new technology and not a good driver, so thanks for your patience. Okay, let's try the motion over.
So we heard a motion.
Can I interrupt?
Yes.
I'm sorry.
Tammy, go ahead.
Kara, oh, thank you. Kara, when you took roll call, John wasn't here yet, but John has popped in. I just wanted you to document that in your roll call.
I see him now. John, you're there?
Yep, I'm here.
Okay, perfect. Thank you. Thanks.
I'm kind of in the restaurant, so it's loud, so I'll keep it muted, but I'm here.
Okay.
Okay, so we've done roll call. Next issue is review and approve minutes from the December 2022 meeting, or December 22nd. And I heard a motion from Lynn to approve the minutes. Did we have any discussion on that? Or I guess, do we have a second? Margaret, I see as a second. Now do we have any discussion? Seeing no discussion. Oh, I saw Tammy, you took yourself off mute. Was it for discussion or voting?
It's so I can say aye.
Okay. So
I'm getting ready.
all those in favor of approving the minutes say aye.
Aye.
Hi.
Any opposed? Any abstaining? Okay.
Alrighty. Now that
Motion
everyone can hear.
passes. So next up, looks like we have department updates.
So your standing item workers' compensation board case law updates. I saw Robert somewhere. Robert Partington has a quick update, and we emailed yesterday their first quarter report to you, so you've got that. Robert, do you want to chime in and add whatever you're going to add today? Might be. Maybe he has nothing to add. The board may have nothing to
I'm
add.
sorry, I was trying to unmute myself. Sorry about that. I can even start my video if it'll.
Yeah, your audio
Oh,
is.
it won't let me
breaking up
start.
a little bit. There
What?
you are. You're good to go.
Oh yeah, hi. Hi, everyone. Hi, Mark. I just had a quick update from the board. I don't have any specific case law updates from, in addition to the MLAC report we transmitted earlier in the week, but I did want to know that this is about as late breaking as you can get. We've got a new posting on our external website for the attorney fee statistics. They are from 2021, and they just appeared as the first item on our external, or the top item on our external website. What they're doing is, we are a little bit late, but they are compiling statistics from claimants' total attorney fees, defense legal costs, all kinds of graphs and numbers broken down into categories and divided by a number of orders, divided by stipulations versus cases that go to hearing. So there's a lot of information there, and I wanted to just draw everybody's attention to that. So that's all I have. Thanks.
Great. Thank you. I know we have next on the agenda is the Workers' Compensation Division rulemaking update.
Yeah, so the only rulemaking we have going on is our annual medical fee schedule that takes effect on April 1st. And I think the fees are gonna get posted, the draft rules soon-ish, and they'll be open for public comment, so look for those. We try not to do a lot of rulemaking during session out of deference to our stakeholders, so. And us too. So that's the only update on that.
Okay. And I know next we have the revised committee work plan.
Yeah, so members, you should have a red line copy of the revised work plan we discussed last time. And I think Scott and Patrick, you wanted to talk about sort of next steps on that.
Sure, yeah, Patrick, do you want to start?
You could go ahead and start, Scott. I think we met and talked about it.
Yeah, well, one thing that I did want to flag, I know that we've gotten a communication from the Northwest Workers Justice Project and kind of concern about continuing to deal with ongoing retaliation issues and look into that. So I want to kind of state that I am interested definitely, and I think that the labor side is interested in continuing to keep that on the work plan. That's one of the reasons why we've kind of prioritized that, and not just investigating retaliation, but kind of ways to address those issues in an ongoing sort of systemic fix. So I did want to flag that issue. And I know that Patrick and I had, some communications about it and how we were going to move forward on a lot of these issues. I think the updated worksheet is more to kind of flag the issues for stakeholders of things that we, on an ongoing basis, will be addressing and going through. We know that we'll have our plate probably full with things, at least through session, but that these are sort of recurring themes that we picked up through the last few sessions and iterations of the MLAC group that we have now. So I think that kind of touches on some of what we talked about, but Patrick, are there any blanks you'd like to fill in there?
No, I agree with everything that you said. I feel as though the work plan itself, I walked in with it in place, and I know you developed it originally with Lynn and Tammy, and I think maybe Jill, was Jill involved with that as well? When you originally met, I felt like being a new person on MLAC, and I know members change from time to time. We'll have some new ones coming up. It helps focus what seems to be important, and I think it was very effective. And I just wanted to recognize the success of completing a few items, and that the edits reflect some items that we addressed and dealt with. And I think the item that you recognized about retaliation, I was encouraged to hear that somebody looked at our work plan and was interested. So I think that was, very positive developments, and hopefully maybe even after the legislative session and in the rush that we have is to re-engage and to consider things that we should look at. So that's my feedback. Thank you for giving me the opportunity.
Sure. And I see Sarah with a hand.
Thank you, Scott. My only comment is I hope that we can be proactive in our work plan, because I think to move forward, we need to start addressing these items. So I appreciate that we have some focus down on paper, but I would like to make sure we have the resources to help ensure we have a proactive approach and can actually address these items instead of passively. So thank you.
Yeah, and I think that's a great point, that, we want to make sure that we're, part of the purpose of this group is to be proactive and assertive in these issues. And I think I'm excited to see some of the stakeholder involvement already with Northwest Workers Justice Project reaching out about that as well. But I think that's right, Sarah, that we need to be sort of pursuing these things actively. I see a hand from Margaret.
Right. I agree with Sarah, but I wanted to ask Sarah if she had any particular ideas of how we could become more proactive on the items that are listed in our work plan. Because if she sees something, I'd certainly like to talk with her, or, maybe we can figure out a way to get those ideas of how to be proactive on the table.
Thank you, Margaret. I think we all agree that the top bullet points were at the forefront. And I think just ensuring that we have ample resources through the Workers' Comp Division to address these. We can proactively ask stakeholders to come and help and start developing committees and, making sure we have updates to ensure all items are met. Or just some thoughts. I don't know if that answers that. I think just keeping it at the forefront of our minds, at every meeting, and ensuring when agendas are set that we have items on here, they're light agendas, to make sure that we are moving forward.
I think that was kind of some of the discussion that Patrick and I had of, using this as the sort of list whenever there's a lighter agenda that we can kind of pull a topic off of this list and begin to dive into that and drill in. So, any other questions or discussion on that topic? I see we have Dave Barenberg with Safe in the room.
Yeah, a voice from the peanut gallery. One suggestion that I would make is that maybe you, seeing the stakeholder involvement in the piece from Northwest Workers Justice, is at some point schedule almost a hearing and invite different constituencies in to speak to the points and what they see as the problems that they're actually encountering that could then maybe guide you in formulating how you want to approach the issue.
Thanks, Dave.
Any other? I see Tammy.
On the what Sarah kind of mentioned briefly about is the help from the department, and that's something that we're going to need help on if we're going to, add the QR code to the 801 or to the 827. First of all, that's going to have to link to somewhere, and then what materials do we want that to link to? So that's directly going to have to be involvement from the department there, and what kind of help in loading all the material on there. So I like Dave's idea about first finding out exactly what the issues are and what we would like to see on there, and talk to the department on how we can start implementing, that little piece. It's almost like we have to take, item by item by item.
Yeah, I think that's a good example. Any other discussion or questions about that topic? Seeing none, I think the next thing that we have is the update on WCD streamlining communications to workers project.
Good morning, everybody. Thanks, Scott. Sally Cohen, Administrator of the Workers' Compensation Division. I'm happy to be with you all here today, and my comments are fit nicely into the conversation you all just had, because this is an update on one of the specific items on your work list. It's been a little while since we've talked about this here at MLAC, so just a little reminder of context where this project came from. We are in the midst of a large modernization program here at WCD, and we engaged a consultant some time back to help us plan out the roadmap for how we want to eventually do large-scale modernization of our systems. Part of the consultant's work involved talking with our stakeholders and also with our staff and everyone who comes in contact with the processes the division currently has, and just asking a lot of questions about where the pain points were, where could we make improvements beyond just stopping paper processes and having more automated processes. What exactly, where could we make some intermediate improvements? And so our consultant gave us a whole list of intermediate kind of process improvement projects, things we could implement using existing resources while we're planning for larger scale system replacements out in the future. And so this came out of one of the suggestions that they gave us for a process improvement project that they had heard loud and clearly from our stakeholders, that communications to workers are confusing and we need to do something about simplifying those. So we initiated an actual project to address that issue. And so we've had a project team working on this. We initially identified more than 50 instances of required language across our forms, our bulletins, our publications, and also in our administrative rules. So we knew we needed to try to, narrow that down to something manageable. And so we had a stakeholder meeting. We got lots of great feedback. I know some of the MLAC committee members participated in that stakeholder meeting, along with a lot of our other stakeholders. And we were able to narrow down the focus of what we want to work on first, and that is the actual language in the administrative rules where it prescribes specific language that insurers are to use in communications to workers. So we ended up landing on that as being our focus of this project. We've done a lot of work with that language, doing an analysis of even narrowing that down. We still ended up with a list of about 35-ish, I think, specific places in our administrative rules that has for actual prescribed language to use in notices. And so we used a weighted matrix to prioritize, which things would have the most bang for the buck, where could we start? And we used investigated and used a number of different readability tools and landed on something called a Hemingway editor tool. We have a link to that. I will tell you, we'll be able to share that with you. It's kind of a cool readability tool. But we also had other factors in our matrix to help us decide where to start. The impact, how broad is this a general notice that all workers receive? The benefits, does it actually impact the access to benefits? The history of have we received prior requests from stakeholders that this is a problem area? is there a statutory change that would be required, and the timing of, do we have upcoming rulemaking already addressing that division of rules? And so we were able to come up with a prioritized list. A couple of the items that we know have been talked about a lot and the stakeholders have really asked for are the required language regarding that are prescribed for notices of denial and notices of acceptance. Those are actually prescribed by the Workers' Compensation Board's administrative rules. We did speak directly to Board Chair Wold about this, and so it is on her radar. And I don't know if Robert is still logged on or not, but the board has a specific rulemaking process where they need to have a petition for rulemaking submitted. And so we alerted Chair Wold about that, and so she was going to follow up with her folks and stakeholders about that. So it's something that we'll have to coordinate both the division and the board on those notices. We are currently doing initial work with our policy team and our project team on trying to come up with what some, suggested changes would be to those notice language paragraphs. We have also made a commitment through our strategic plan for 2023 that for every rural division that we do open up, we will be addressing those specific prescribed language paragraphs in the rulemaking when we open the rules. As Kara noted just a moment ago, we don't normally do a lot of rulemaking during legislative session, but we know we'll be hitting that hard and heavy this summer. One thing that we would really like now is to be able to test out some suggestions on actual real people. Your committee discussed, I think it was the last meeting we talked about needing to actually get to the end users. It's one thing to have a rulemaking advisory committee meeting where stakeholders come in and talk about this, but it's another thing entirely to see how this actually resonates with end users of our system, with actual workers and employers who are the participants in our system. So we're looking for ideas for opportunities that we could do some testing and getting feedback prior to going into the actual rulemaking. Since that is a real formal process, we'd like to have some more informal opportunities to connect with our stakeholders. So we welcome your input on that. The other thing that we did, and we sent out a stakeholder update document through our modernization program the end of December. And so hopefully some of you receive that if you're subscribed to receive our updates from our modernization program. If you're not and you'd like to get on that list, please let us know. We'll help you get subscribed to that. But we did send out a pretty detailed response to stakeholders, identifying kind of our update on where we are with this project, but also to Tammy's point a moment ago, the specific items that are listed on your work list. There are a lot of very specific things about adding QR codes to particular documents. A lot of that conversation came up in our stakeholder meeting, and we've tried to outline our responses to each of those items. And some of those things are indeed doable. Technologically wise with our existing resources and our existing technology, like adding QR codes, for example. We do need to have more conversation with stakeholders about what specifically are the like for a QR code, for example, where does it make the most sense for it to open up to, which website should it open up to, those kinds of things. So we are asking for specific feedback from stakeholders. In our response document, we did put links to our request form, and it's called a possible rule issue form. Don't get hung up on the wording on that. It is a link to be able to submit specific requests and suggestions to the division. That form goes directly to our policy unit. So that's why we're suggesting using that specific form, because it will go directly to a policy analyst and get reviewed, and then we can vet it out here at the division. So we have added the links to that. on each of those specific topics that were raised. And so we are really looking for some very specific suggestions from stakeholders about how to move forward on some of those things. So I think that's about all I had to share. I'm happy to answer any other questions or anything else that the committee members might need to know.
I see Sarah has a hand raised.
Thank you, Scott, and thank you, Sally, for the update. You're describing a very long process, and I get that, and it makes sense. So I appreciate that description. A quick question: I did get the update, but I don't know if I got it forwarded to me or not. Could you maybe include all MLAC members?
Yeah, that's fine. We're happy to do that. We'll email this out and also give you the information about how you can do the Gov delivery subscription. So you
Okay, I don't remember if it was forwarded to us
Yeah.
or direct, but I did read it and I found it very informative. And I like to see the progress is moving forward. And then when do you expect deliverables to be, I through your process, I know it's lengthy, and just a ballpark, any sort of deliverable updates that will hit the end user?
Yeah, so these items will require rulemaking for us to be able to modify the specific prescribed paragraphs for notices. So we will not be opening up rules until later this summer. And then there is approximately, I want to say, someone else on my team can correct me how many days we do for rulemaking, but it's a couple month process. So
okay, so nothing until
yeah,
fall or
right.
late fall. Okay, thank you for your updates. I appreciate it.
Mm-hmm.
Any other questions or comments about that? I see Dustin has a hand raised.
Yes, thank you. Dustin Carstetter, Washington County Risk Management. I just had a real quick question related to carryovers from the 2022 session, just kind of going back to the work plan momentarily. In regard to the subcommittee being on hold, I'm curious in regard to the information that is being requested or hoping to be received to kind of reopen and reinitiate that process. Is there any guidance in regard to how historical that data needs to be? In regard to, obviously the point is to identify it being a current issue of the, related to not having end dates on time loss releases and whatnot. Is there any guidance on how far back you want that information, or to just focus on maybe the last year or two, just to determine whether it's a current problem or something maybe a little bit more systemic? Is there any guidance that I think either Sarah or Matt would ideally be able to offer, since you guys were leading that subcommittee?
Matt, do you have thoughts, or do you want me to go first?
Yeah, I don't have any guidance with that one. Go right ahead.
I'm not sure I have guidance either. I think we're willing to look at the data. I would suggest the last couple of years might be ample, but I think we just have to wait and see what can be provided. And is that accurate, Matt, or?
Yeah, and it seems like folks would have, from discussions in the past, folks haven't gathered that data and we're unsure of how they would go about. So I think identifying what is available and maybe doing some preliminary work. I don't want to dive into like 5 years of records to see what we can gather, but establishing what's available and sorting that out would be a first step. And I don't know timelines wise.
Yeah, I would think a couple years would be ample.
Okay.
If there's appropriate data within those few years.
All right, thank you.
Any other questions or comments about department updates?
I have two quick things. Just tomorrow, MAC is meeting to talk about your request on the best practices. So Sally and I will be there for that discussion. And just for legislative update, there's not a ton of directly impactful workers' compensation bills right now, but they're not done yet. So more to come on that. And that's a good segue to the next topic. You should have a bunch of materials that you got by email on LC 1486. Dr. Sabo is going to chime in here in just a second. The bill hasn't been introduced yet. It's still in LC form. We sent an analysis from the department out with your packets and a couple of items that Dr. Sabo is going to talk through in his testimony. And he's got a presentation that Brittany's going to share up here, I think, on the screen, Dr. Sabo. So we'll get that going while you could talk.
Yes, Dr. Vern Sabo, representing the Oregon Chiropractic Association. This legislation is about injured workers and getting them quality, respectful care. And we would respectfully suggest that that's, in many cases, that's not happening, especially when it comes to common back, neck, lower back injuries, the very things that we treat and arguably are the best provider to administer those interventions. And we would say the arbitrary restrictions that consumers injured on the job, the restrictions to chiropractic physicians is in part causing that poor care and then also increased costs. I don't need, nor do most of my colleagues need workers' comp cases in our practices. Where I'm very busy, most of my colleagues are, but this is about doing the right thing for injured workers. As I say, with common back, neck, lower back injuries. You know, I treat a lot of Oregon health plan patients. I treat a lot of general health insurance patients, PIP cases and so forth. And the my practice and most of my colleagues, the rewards come from the testimonials, the outcomes of our patients. That's what's heartwarming. That's what keeps me in practice. That's why I love what I do. I have no plans of completely retiring. I'm approaching my 42nd year of practice, and I love what I do. And currently, many injured workers are getting substandard, inferior care. And what's occurring, not all, but what's occurring, especially in my area, and I'll show examples of this, is many of the injured workers are being funneled into the local occupational medical clinics or urgent care clinics, never being told that they can see a chiropractor or go to the healthcare provider of their choice. And once there, we're getting reports back from the injured workers that of care that's just not good. It's not quality care, and I'll show you examples of that. I have a little over 200 medical professionals in the surrounding communities that send me cases, medical physicians, osteopathic physicians, nurse practitioners, physician's assistants, nurse midwives, certified midwives. And I require as much as possible that the most recent medical records are sent ahead of those patients. And invariably I see in their medical records a work comp related injury, and they're coming to me. There seems to be a propensity of these in the Oregon health plan patients, Medicaid patients, where there's this history of a work-related injury, and they're coming to me for that same injury, neck, low back, whatever, never resolved. And I look at the treatment or lack thereof that they received. It's never been resolved. And more times than not, I'll ask them, well, why was your claim closed? And they have not a clue. Almost to the worker, they have no idea. And so, and then they see me, and in a matter of literally 1, 2, 3 treatments, and they are 50, 80% improved in many, many, many cases. And so very thankful, and part of why I love what I do. Can I get the next slide, please? So this is a local occupational medical clinic in my hometown. It has 27 reviews. There's actually 28 now. Their star review is 1.7 stars. And this is a affirmation of not all, but what many injured workers are dealing with. Next slide. These are screenshots from their actual webpage. Terrible place, waited for over 35 minutes to be seen, rude people. If 0 was a rating, I'd give it. Next slide. Injured workers deserve better than this. When you arrive at 7 minutes before scheduled time and they make you reschedule because you weren't here 15 minutes earlier, every time I come here, I'm made to wait 30 plus minutes after scheduled appointment to be seen anyway. Frustrating, they hold the monopoly on occupational things. Next slide. The staff here is extremely rude. I would not recommend going here. You've had a bad experience and it's not worth going through the intensity of their poor customer service. Next slide. I just have a few of these. I'm not going to show all of them. Wow, so unprofessional. I heard the ladies talking about me behind the window. The one said I can kiss her blank because I didn't realize they were understaffed and had to cancel another appointment because I was already checked in. Next slide. Has the worst bedside manner of any doctor I've ever had the misfortune of dealing with. I personally think she works for the insurance companies directly. Next slide. They deserve 0 stars. They are very rude and the whole place smells really bad. I'm not sure if it was from the people that work there or what it was. Hard spending an hour waiting in this place. Next slide. Extremely inefficient, very rude. I would not recommend. Next slide. I think that's enough. I'm not going to read anymore. So people deserve better, especially injured workers, and we're arguably the best at treating common back and neck injuries that are non-surgical. Chiropractic physicians are first contact portal of entry physician types. Our Oregon Board of Chiropractic Examiners and Licensing Board define doctors of chiropractic because of our scope as primary care physicians. We are responsible for differentially and correlatively diagnosing individuals, recognizing the red flags that can be harbingers to frank pathology, bad diseases that are masquerading as simple mechanical low back pain, and referring for appropriate lab or other imaging, special imaging, or to the correct medical specialty. So the arbitrary restrictions injured workers have to our services is resulting in inferior care and increasing costs, and Dr. Rosner can speak to the cost portion. That's the comments I'd like to make today, and if there's any questions at the appropriate time, we'd be more than willing to answer any. Thank you.
Thank you, Dr. Sabo. Do we have any questions or comments relating to that presentation in particular? Not seeing any. I think the next that we have on the list is Dr. Rosner.
Yes, thank you. Am I coming through?
Yes, we can hear you.
Great. Well, I want to thank the committee for having me join you today to share what I think is a very important report. I always think at the beginning of committee meetings, I'm reminded of the time when the moderator asks, all you introverts out there, please raise your hands. So here I am. And let me begin. Low back pain and neck pain expenditures in the United States entered the top rank of expenditures of over $134 billion in 2016. Now, this put it in the top tier of expensive health conditions. Low back and neck pain expenditures out of workers' compensation and employer costs together, in particular in 2016, were $97.4 billion. Now, 62 billion of that came out of workers' compensation alone. So given today's economy, this makes a cost-effectiveness study, such as the one that I just authored, of paramount importance. Now, your report is demonstrating, with over 50 annotated study reviews, that chiropractic care compared to care by medical doctors and physical therapists provide substantial cost savings, both direct and indirect. Now, this is due to bypassing more costly interventions, shorter treatment periods, and the relative absence of side effects. Specifically, this report is driving home these points with an abundance of studies in the peer-reviewed scientific literature that has demonstrated, number one, reductions of costs when chiropractors are the first point of contact. Now, there are 4 papers to that effect. Number two, reductions of disability in patients under chiropractic care. That's another cost saver. Number three, reductions of surgery and hospitalizations with patients under chiropractic care for musculoskeletal conditions. That's another cost saver. 5 papers to that effect. Number four, reductions of prescription use including opioids, another cost saver, 6 papers to that effect. Number five, reductions of over-the-counter medications, another cost saver. Number six, reductions of imaging, another cost saver. And lastly, number 7, proposed reductions of spine injections. Now, the leading recent studies that we have, dating from 1995 through 2022, that have included, we have 29 papers to that effect. Number 1, databases from insurers and practitioners, 6 papers. Databases from workers' compensation studies and employers. We have 12 papers to that effect. And this includes the states of Utah, Florida, Texas, North Carolina, Manitoba in Canada, New Jersey, and 28 states that have been called by the Workmen's Compensation Research Institute that I've worked with closely in Cambridge, here in Massachusetts. Number 3, databases from clinical studies, 5 papers to that effect. And number 4, databases from Medicare and Medicaid studies, 6 papers. Now, there's clearly been a rapid cost growth of workers' compensation costs in the 1990s. That is coupled with the idea that chiropractic care and physical medicine were part of the cost drivers. However, this report includes studies that demonstrate that patients use chiropractic care as a substitution rather than an add-on. And that defeats the argument that chiropractic care increases cost burdens. Now, we have one representative table that shows workers' compensation distributions in the state of Georgia. For example, that low back pain represents 33% of all workers' compensation costs and 16% of all workers' compensation claims. Now, chiropractic care gets less than 2% of workers' compensation benefits paid out each year from 2003 through 2008. Physical therapists, on the other hand, received 15 to 22% of those reimbursements. At the state level, we have multiple reports showing a drastic reduction of chiropractic income for workers' compensation starting in the 1990s, while musculoskeletal costs have risen sharply with the utilization of other healthcare providers, which showed no such decrease. Maintenance care now is also being shortchanged, and it fails to be recognized that a wealth of studies have shown that extended maintenance care prevents episodes from flaring up and having to be treated from the beginning with full history taking, physical examinations, and so on, greatly increasing costs when such measures are really not necessary. It's important to note also that in workers' compensation studies, the chiropractic care not only accelerates the time to return to work, but increases the work efficiency on site as well. That's a huge factor in indirect costs. So these are all important cost savings that have to be tabulated, as I said, as indirect cost factors. Now, we also have a few studies that provide erroneous cost comparisons by neglecting to include referrals, medications, hospitalizations, laboratory costs, and imaging on the medical ledger, whereas most costs are bundled together in the figures that are provided with chiropractic care. Elsewhere, our report presented several papers that demonstrated that there was a significant deficiency in proficiency in training of medical doctors in musculoskeletal medicine. In fact, there's a study of the websites of all 141 United States medical schools that reviewed the content of their clinical curricula showed that, quote, given the high prevalence and burdens of musculoskeletal disorders, required experience in musculoskeletal medicine continues to be underrepresented. What about the argument that chiropractors could make herniated disc injuries worse? Well, the incidence of cauda equina syndrome that would result from lumbar manipulations is 1 per 100 million. Now that's 1/1000th the chance of being killed by lightning. In addition, a recent population self-controlled study showed that there was no evidence of excess risk for acute lumbar disc herniation compared with primary medical care. And other studies have actually reported the successful treatment of herniated disc by spinal manipulation with no adverse events reported. A leading professor in health economics at the University of Ottawa produced a report demonstrating that improved access to chiropractic services in Ontario would result in the doubling of chiropractic services from 10 to 20%. What would that produce? Well, it produced savings of 548 million in direct costs. And here's that indirect cost factor, 1.25 million to 3.775 billion in those indirect costs. So wrapping up, the impediments to extended chiropractic care significantly increase rather than reduce healthcare costs overall and need to be revisited. These restrictions block the multiple routes to cost savings that are afforded by chiropractic care shown in this report. To the point, there exists an abundance of areas of cost savings delivered with chiropractic care that need to be recognized and utilized, overwhelmingly supported in the scientific peer-reviewed literature that's been laid out in detail in this report. And thank you.
Thank you. Do we have any questions or comments? I see Matt.
Thank you, Dr. Rosner. You had mentioned just one outcome with the lumbar manipulation, the cauda equina syndrome. What about data on, because that's only lumbar manipulation, right? So that isn't looking at cervical spine.
You're going to cervical, I bet. Is that?
Yeah. So what about like outcomes with cervical spine manipulation, strokes, things like that?
That's a huge topic. And I've written several papers to that effect, actually. It's a matter, first of all, of what the patient is coming in with. A lot of times there are predispositions to dissections where people have gotten on the table and not been touched and suddenly had an event occur. There are cases where I think you can show, if you measure things like homocysteine, for instance, this causes a lot of the dissections that have been reported. There are a couple of procedures that are being discouraged, such as extreme rotary manipulations, and people have been, drifting towards side posture manipulation. But the incidence of these events has been extremely low. And there was a study by Cassidy, in fact, that showed that the events that occurred with patients compared to medical doctors, it was equal or even more in the raw data. So it's a problem, of course, that you want to face, but I would mention it in, informed consent statements as a possibility, just as you see side effects for, medications, but it is extremely rare. And I've been very concerned again, about the physiology, the events that precipitate that. And interestingly enough, I'm going into a sidebar here. There are a number of vitamins that actually lower homocysteine, which destroys the wall of the artery and is really responsible for a lot of dissections that have occurred. So you do raise a very interesting point, and it's one that we, of course, are very concerned with. Yeah.
Thank you.
Other hands.
Yeah, I see Lynn, and then I see Dr. Sabo again. So I'll start off with Lynn.
Thanks, Scott. Dr. Rosner, I read the materials actually before you presented them, and I was wondering, and it noted the focus on cost, and I was wondering, are there studies that you're aware of that compare time of return to work
Yes.
between
goodness.
chiropractic and
Yeah, it's
medical?
in the report, I think, actually, it's a lot faster with chiropractic care. Again, it's question of who was the first provider. And, to be truthful, that provider has to be quick in referring, more serious cases to other providers. But at the same time, a lot of what does occur could be prevented with chiropractors as the first provider. But there are some studies in the report that I think have mentioned, that there are quicker returns to work at several levels. And that, of course, is one part of the equation. The other is, if you're at work, are you functioning at full capacity? And I think that's another thing that's been demonstrated, that I'm trying to think, James Whedon, I think, has done most of the work in that area. And it's quite impressive.
Yeah, and if there is other information along those lines, because I caught one reference to it in the report, but if there are other reports that you're aware of that you could forward to MLAC to share with the committee, that would be helpful.
Okay.
And I see Dr. Sabo.
Yes, I wanted to refer to Matt's question about what he's referring to as a vertebral artery dissection, which is extremely rare. It's tearing the vertebral artery and subsequent stroke. I'm board certified in neurology, and Dr. Rosner is referring to Cassidy's study, which showed that the incidence of spontaneous dissection and stroke in the general population of primary care physicians was greater than the population seeing chiropractors, who, of course, one of our principal interventions for neck pain, neck dysfunction, joint dysfunction, spinal manipulation. And so what all of the evidence shows is that the folks who are having dissections, vertebral artery dissections, are spontaneous, and they have a pre-existing arteropathy. They have pre-existing weak vessels, and usually has a family history of aneurysms and vessel disease and so forth. It's very rare, but collagen vascular diseases and so forth. And that's part of our history taking. Those are the folks that are predisposed to vertebral artery dissection, but it's very, very, very rare. To put it in context, as far as adverse events and seriousness of this, the accepted mortality rate of general anesthesia is 1 to 10 per 10,000. That's 800 to 1,000 per million that simply don't wake up from the anesthesia. They go into anaphylaxis. The incidence of actual stroke and death with cervical manipulation by chiropractors is 1 in 10 million. Neurologic events, 1 in a million. So it's almost not even worth mentioning. It's a non-entity. It's rare. And Herzog, for instance, and on the last comment, has shown that with mechanical and piezoelectric sensors, that it took 10 times the force of a chiropractic spinal manipulation or adjustment to cause a vertebral or a healthy vertebral artery to fail. So the folks that are stroking are have pre-existing arteropathies or weak vessels.
Thank you.
Do we have any other questions? I guess a point of clarification in listening to, I was a bit of a broken record when we went over the MCO stuff a few months back, but kind of framing everything in MLAC's lens that we've stated, the way that we analyze issues and view things through of balance and fairness, adequacy of benefits, affordability, efficiency, stability, and flexibility. So if I'm taking from your presentations from it what you like, I'm hearing a lot about risk and cost, addressing kind of some of these topics, but I'm also kind of hearing a theme of access and flexibility of providing care for workers. Is there any data that you have on the impacts to access to care, or you've mentioned that there's better capacity when workers return to work, and that there's some evidence of faster return to work, addressing Lynn's question. But are there any other evidence and studies kind of expanding from just cost, because there's cost and then there's actual outcomes, and then there's all of these other issues with balance and fairness that we deal with. Do you have any other evidence? I know Dr. Sabo had some kind of the anecdotal point about the occupational medicine clinic.
I would like to speak to that if I could, when you're ready.
Sure, yeah. So kind of any other information that you have on that, I think if you're prepared now, that would be great. But otherwise, if you have follow-up, I would love to see that. But
Well,
go ahead,
as far as efficacy of what we do with our principal intervention is spinal manipulation. By the way, we're a one-stop shop. We do our own physiotherapies, we do our own imaging, and so forth. So that's one of the cost savings. But as far as efficacy and outcomes and helping people and getting people better, the reason why 1.2 million Oregonians on the Oregon Health Plan can now get chiropractic spinal manipulation is because of the high quality evidence of efficacy. And when I say high quality, we're talking about randomized controlled, well-designed, large randomized controlled trials. That evidence was synthesized with Oregon Health Science University Center for Evidence-Based Policy. I sat on the Health Evidence Review Commission subcommittee. Ariel Smith was the chair of our Prioritized List Reorganization Task Force. We changed Oregon state policy because of the evidence of efficacy. The Oregon Health Plan simply will not pay for any interventions that don't have high quality evidence of efficacy because we have limited state and matching federal funds to administer the Oregon Health Plan. So there's a ton of evidence, overwhelming evidence as far as the effectiveness of our care and outcomes.
Thank you. And I see Sarah's hand.
Thank you, Scott. And so Dr. Rosner, I heard you say that within one to 3 visits, there's an extreme amount of improvement from chiropractic care. And currently the system provides 16 visits for a chiropractor to be a primary care physician. So it seems like this can be treated within those 16 visits and return an injured worker back to work. I don't know if that's a question more than a statement. I'm not sure.
That was my comment. And that was anecdotal of the folks that come into me, and it's true. We get folks 50, 80% better, a great number of them within 1 to 3 visits. And that's the great majority of folks we can take care of within that 18 visit window. The trouble is partly access and impediments to access to our care. The second part of that is the more problematic cases. I specialize in the treatment of disc herniations and stenosis. I have a specialized table, COG7 table that does flexion, distraction, decompression. And there's a level of evidence that supports that. And anecdotally, I can tell you, I can help 50 to 60% of the radiculopathies, low back, is that's a fancy term for pinched nerve due to bulging disc catching it. I can improve their pain nerve symptoms to a degree to where they don't have to go on to surgery. Those are the folks who represent the greatest cost to the system. And we lose those folks after 15, 18 visits. And then the access problem is the other issue, is just getting to us in the first place. There are significant barriers. And part of that is our not having full attending physician status for the life of the claim.
Can't injured workers choose their provider?
Well, that's what how the system is supposed to work. But the reality is many of them are being told they can't go anywhere else. They must go to the occupational medical clinic or the urgent care clinic. Now, it's right and true that they can require their injured workers, if it's their policy, to get drug testing, which makes perfect sense. But once captured at the OcMed clinic, they're never told they can go elsewhere. And then they receive that care many times, as I described, reading those screenshots. So, and then the other aspect is enrollment into managed care organizations. I'm a panel provider of Majoris. Many of them are very restrictive. The issue is once the great majority of people we can get fixed within 12 to 18 visits. But it's the more problematic cases who tend to end up having impairment, permanent spinal impairment that's measurable, that need prolonged care, take longer to treat. And those are the folks that we lose because we have to get permission from the medical director for ongoing care, and that's not forthcoming many times. And then we lose them. We never see them again. If Safe Corporation, I think there's a Safe individual on here, the Safe Corporation at a recent meeting, not recent, a couple of years ago, at a disability rating administrative rules hearing, the claims reps from Safe Corporations told me that the great majority of the closing examinations are performed by the IME vendors. And that is not a good situation for injured workers. A 2004 DCBS IME report in their executive summary specifically stated that 52% of the IME doctors working for the IME vendors themselves said the system was skewed against injured workers. And that's just, injured workers deserve better.
Thank you.
And I see Tammy's hand and another hand after that.
Hi, Dr. Sabo, Tammy Bowers here. I wanted to ask about that access of care. You kind of touched on it a little bit, and we've been looking at access to care, quite a bit on in the claims processing and the injured workers that have to wait 2-3 months to be able to see an orthopedic surgeon or something like that, to see specialty care. And it's because of the volume. After COVID, the volume is extreme, and a lot of physicians have retired after COVID or during COVID. So our opinion or our history or experience has been looking more that there's just not enough facilities, and that's not something MLAC is going to be able to fix. But in that lens, looking at chiropractic care, I've never had any of my injured workers having trouble finding a doctor or a chiropractor. So I'm wondering exactly what you mean by access to care.
Well, first of all, the number of chiropractors allowed on the different MCO panels varies greatly. There are some that have very restricted access. And so the injured worker, when they're told they can, when they're actually told they can see a chiropractor or the healthcare provider of their choice, finding or even going back to the chiropractor they know is restricted because they're not on the panel. The other part of that is once they've started treating with that injured worker, if it's a problematic case, they'll lose that case if they're not referred back to by the medical advisor. Some of the MCOs restrict attending physician status within the MCO. So once the case goes beyond, I think it's 18 visits for not Progressive, but Providence. There's another one I think is restricted to 18 visits. They lose that patient and they don't have access to the chiropractor after that. I'm not sure if I answered your question.
Yeah, okay, but that's just in the MCO, not in the, there's
Right.
so many that are not part of the MCO. Okay, so yeah, I believe the rule is 60 days or 18 visits. And when you're talking about most of these, the majority of these problems are fixed in just a few visits, you could absolutely be the attending physician. And then after the 60 days, the physician can refer back to you for an unlimited period of time. Isn't that correct?
But that doesn't happen. That just doesn't happen. They're not referring back, and that's part of the issue.
Okay,
Yeah.
thank you.
I think there's another,
To clarify, Dr. Sabo, your point is that may theoretically be, or that is on paper, the law, but that doesn't ever occur, or that you experience? Is that what you're trying to say?
Well, I wouldn't say that it doesn't ever occur. It's rare. The majority of the cases is they're not referred to, and the great majority. I have, like I say, over 200 medical professionals that send me cases. None of them will take workers' comp cases. The hospital physician organization requires all of them to go to the OCMED clinic, and you saw examples of the care that's provided.
Yeah, I'm sorry, but I just don't think it's appropriate to look at reviews at one specific Albany occupational health clinic when there's so many other ones that, have great reviews. That just in the middle of an MLAC, a recorded MLAC meeting, I'm sorry, I just don't think that is appropriate.
I'm sorry, I didn't understand what you thought was inappropriate.
I mean, to look at the reviews, all the bad reviews only at one specific clinic in Albany without inviting that specific clinic to, you know, speak or defend themselves, it just doesn't seem, I don't know, quite kosher to me.
Well, it's their webpage. I'm just taking the information off their own webpage. I'm not,
Sorry.
and those are the stories I hear every day. So that's the truth, and it's on their webpage.
Do I see Dr. Rosner's hand?
Yeah, two issues. I guess one has to do with those cases that Dr. Sable said, you know, are they really cost-bearing ones that are multiple visits? I cited a number of maintenance care studies that really have to be appreciated because it has to do with continuity. And it's those cases that are recalcitrant in which there is already a good rapport between patient and doctor that have gone on for as long as 5 months or longer. And the whole logic is to avoid having a flare-up where the patient comes back and has to be reevaluated, history, physical examination, very, very big cost issues that don't happen if there is continuity of care. And so for these patients who are undergoing maintenance care, and there were maybe 5 papers or so that were in the report that describe this, there are advantages to considering that. That's one issue. Now, the other has to do with access. And in the report, I guess under Medicare patients, there were questions of access and relocation. And what happened is when patients didn't have access to chiropractic care, and this was a study by Davis, that were looking at reduction of access to chiropractic care, and it produces an additional cost. I guess this is one item that I'm just teasing out of the report, $8,075 per 1,000 beneficiaries on primary care and $106,000 on spine surgeries. These are additional costs because of reduced access to chiropractic care. So I realize I'm going from Medicare to workers' comp, but I think there's an issue that has to do with contact, continuity, and you know, efficiency. And it's good that we have the first contact with chiropractors, you know, that I think has to be emphasized. But it also has to do with access and continuity issues. And so I guess those are my 2 cents.
Thank you. I see Matt's hand, and then I think we have someone in the audience here after that.
I just wanted to follow up on that, Dr. Rosner. In the New England Journal of Medicine article cited in your work there, the conclusion was that there was no clear advantage of chiropractic manipulation over physical therapy. So, and they even define that in terms of either effectiveness or cost. So with that maintenance care, it seems that PT, per that article, and I haven't had a chance to go through all of your citations, but that one did seem to identify.
Yeah, that's on my screen as well. And unfortunately, there were lots of flaws in the methodology as to how patients were sampled, what were their baselines, and how are the costs actually calculated. And this was Carrie's article, or it was, I'm trying to remember. I remember those articles.
This was looks like by Churkin.
Churkin's article, 1998 October. Yes. And yeah, I mean, first of all, the patients that went into chiropractic care were severely disadvantaged. I mean, if you look at the, you know, baseline conditions, they were at a disadvantage. And for some reason, the costs, I think there was a surcharge of 50% that was tacked onto the chiropractic cohort for HMO studies, for HMO care, that wasn't even explained. And I remember that very distinctly. And I actually wrote, I can send it to you, an extended dissection of the article. There were several points that were deficient. And I must say that I think it was a council of chiropractors in the United Kingdom took one look at the study, and they said it's meaningless. It is so deficient that it has no bearing whatsoever. And I know it was the New England Journal of Medicine, but I actually was one of the reviewers of that paper. As it turns out, I have to tell you, I did to that paper what General Sherman did to Atlanta, but there were 6 other reviewers who thought it was just great. So it got published. And there is a backstory to this, but I will not get into it.
Thank you.
So there were comment from the audience, then I see Dr. Sabo's hand up again.
Yeah, I just briefly wanted one thing that needs to be understood is that we're a one-stop shop. I mentioned this earlier. We do all the physiotherapies, including rehab and all the physical medicine interventions, but all the modalities, all the different types of physiotherapy machines like ultrasound, galvanic, diathermy, low-level laser, and so forth. And so any clinician worth his salt has got multiple tools in his toolbox, and you utilize a tool or combination of tools that the evidence and your experience tells you will be best for that injured worker. So to take one modality, spinal manipulation, which has high quality evidence, out of context and suggest that that's the only thing we do to help injured workers is nonsense. It's just not the real world. I pull out every tool in my toolbox to help folks. And so at the end, that ends up being better outcomes, not only that, but reduced costs when we do everything in our one-shop stop.
Thank you. So I see, again, the audience, and then I see another hand as well on that thing. So go ahead, David.
Dave Berenberg from SAFE, and I'm sort of getting in this because we were mentioned. SAFE supports the existing system where a chiropractor can be the attending physician at the beginning of a claim for up to 60 days with 18 visits. We also believe that when cases are complicated and go for a longer time, that it is in the best interest of the worker and the system that they be seen by a physician or an OD to then manage their care. Looking at the cost issue, just want to remind folks that one of the major drivers of cost increases that had the system in crisis in the 80s and was addressed in the way that the hierarchy of attending physicians was established was chiropractic care. It was one of the things that was one of the major cost drivers at the time. And the system was clearly in crisis, and that was one of the major reasons that was pushing it that way at the time. And so, we believe that insurers are always looking to try to get the best outcomes at the lowest cost if we can, because that's the business that we're partially in, with a focus on, also the workers' health and safety. But we just still believe that the current system is what's in the best interest. And just wanted to remind folks about the past. And last point, which is, again, there's no limit on the amount of chiropractic care that can be prescribed in the system. 18 visits by a chiropractor at the outset, and then there is no cap on visits. I understand the points being made that, well, there are other modalities that people are directed towards, but there is no hard limit on chiropractic care that can be prescribed by other practitioners that have other standings in the system.
May I respond to that?
Briefly,
Briefly?
we have Dustin's hand first, and then I can circle back to you.
Okay, thank you.
Yes, just an additional question, and obviously I would very much welcome a response, possibly directly from Dr. Sabo. In a lot of this discussion, there is an existing system where, chiropractor can initially act as the attending physician and gets a number of visits. And Dr. Sabo, you specifically mentioned that, you guys are kind of a one-stop shop. And I was hoping that you could kind of speak to situations where, you brought up herniated discs, disc impingements, radiculopathies, these things of that nature. In your request to be considered for attending physician status, can you speak to situations where surgical intervention is necessary, where it's not determined that chiropractic care can resolve whatever the issue might be, and what that process would look like of you guys referring people back to surgical care, and what the prevalence of that is? I mean, how many of your normal patients do you ultimately determine do require surgical care or surgical intervention? and what that referral process would look like?
Yeah, absolutely. It's, I work with the local neurosurgeons at Samaritan, and it's a low percentage of individuals that have to go on to surgery. And that's where your clinical skills come in, is the presenting neurologic findings. The folks that go on to surgery are the ones that end up with unrelenting pain down their leg or arm, but more importantly, when they start to develop paresis or weakness in that part. And it's our responsibility, and we will be held to that, to refer in a timely manner and get them to a surgeon when surgery is necessary, because that foot drop or that weakness, bowel bladder dysfunction can be permanent if you don't refer in a timely manner. So we're on the hot seat, and that's what we differentially diagnose for. Now, with that said, I can tell you, the medical professionals that send me, I can't begin to tell you the number of inappropriate referrals for special imaging that no reflexive sensation muscle testing, none of the neurologic testing was even performed. It's just that they have pain down their leg or pain down their arm or paresthesia, tingling. And when in fact you do a neurologic exam, there is no neurologic deficits indicating a pinched nerve root. It's referred pain from myofascial trigger points, from bursa, from facet joint syndrome. A myriad of things can cause pain down the arm or leg. And that's where your clinical skills and our clinical skills come into whether or not they really have a possible disc herniation, or is it coming from other areas, muscles and so forth. And that special imaging, which is very expensive, is absolutely not indicated, but I see it all the time. So it cuts both ways, and absolutely it's my responsibility, and it's malpractice if I do not refer in a timely manner.
Then I know you requested a quick response to Mr. Berenberg's.
Oh, yeah, yeah.
Then I saw Dr. Rosner's hand, and then we have someone in person who would like to ask a question or make a comment as well.
Well, part of my future testimony, I don't know if it'll be in front of this committee or the Business and Labor Committee, but I have a slide of a 1988 safe in-house data study, which was utilized the data was utilized inappropriately and mischaracterized the information as far as chiropractic being more costly for an injured worker case average. Now, every profession's got its outliers, those who abuse the system or treat too much, including spine surgeons, and we had ours. Well, lumped all together, as I said, we are a one-stop shop. The average case average in 1988 by SafeZone study, and I have a slide of it, we were $706 per case average back in 1988. What was told by Stanton Long, the then president of Safe Corporation, was that because the average cost of medical care was only $256, chiropractic care was nearly twice as much. What was not told and mischaracterized is the fact that that was just to see the medical physician, the primary care physician, who, if you stop and think about it, when it comes to back and neck injuries, performs no hands-on treatment. What they do is they do one of two things, usually both. They write a prescription for medication and a script for a trial course of physical therapy, usually both. Well, back in 1988, SAFE's own statistics showed that the average case average for medications was $200. The case average for physical therapy, which is a direct medical cost, was $550. And the direct cost for imaging, namely x-rays, was $200 per case average. So if you add it all up, it was nearly $1,300 compared to our $706. We were nearly $500 per case average cheaper with better outcomes, but you never heard that story during the work comp reforms. You're hearing it now, and I've got the slides and documents of that. And Dr. Rosner's talked about the evidence over and over again, showing cost savings, but it really shouldn't be about cost. It should be about getting quality, respectful care for our injured workers. Thank you.
Well, yes, and I think we always at MLAC invite, I know we have some folks that are data nerds on MLAC, definitely. And so we would always invite any parties to submit any of that information. We would love to have that available. So I see Dr. Rosner and then someone in person.
Yeah, I just wanted to add a comment about our referral patterns that may have added to the idea that chiropractors are an add-on. Remember, I had addressed the issue of substitution. And it's really a question of cultural awareness, I suppose. and efficiency of referral, if indeed a chiropractor is the first point of contact, are those patients really the ones that are causing the increase in costs? And I suspect that that's not the case. It may be a case where there is back and forth, where a physician, probably reaches a dead end, sends a patient then to a chiropractor, and guess what? It's an add-on. And again, it's a really question of looking at, how the patterns are achieved, and also referring to Dr. Szabo's fact that I had mentioned in the report also of the bundling issue, which is a huge factor. And I can tell you there are so many papers that have not talked about those ancillary referral costs and all the other services. And so we have to be inclusive and make this very, very clear, how the patterns went down if we're going to do this comparison. And I believe there is some data in the report to support that.
Thank you. Yes, and it does sound too as if there may be some overlap or intersection. I know that, I believe it was Sarah's comment earlier, a question about kind of how, that workers are able to choose their own provider, might have been Tammy as well. And what kind of communications and information are given to the worker when they have the initial incident, that they're able to not, go somewhere other than Ahmed, or if they choose to, go to an Ahmed clinic. So I think that, I would invite you as well to, in addition to what you've done today, maybe get involved in that part of our discussion as part of our work plan as well. So I do see we have someone in person as well.
Hey,
Yeah.
Kirsten Adams with Associated General Contractors. I just want to make a quick comment. We have no issues with chiropractic care, and we think that it can be, a very important tool for injured workers. However, I share the concern that David was brought up of, it's very clear that our system today is a lot better than it was in the 90s, and I think a lot in the early 90s, and a lot of that has to do with the way that status for different providers has been put in place. And so I think making changes to that makes us concerned, because how is that going to impact the overall system and all of the progress we've made since 1990s? So I just wanted to flag that as no concerns with chiropractic care. I think that that's a really important tool, but concerns about a shift to the system as a whole. Thank you.
One final comment, I guess. I'm sorry to butt in, but I did want to point
out. Dr. Rosner, go ahead.
Yeah, the question of training and of competency, and when you have even physicians and studies of medical schools saying, we're short on musculoskeletal training and proficiency, and you see all these papers that I cited at the end of the report on performance in musculoskeletal medicine falling short, you start to see the question, will patients in fact reach a dead end in some cases if they don't consult a chiropractor first? And then I guess the question too, from what Dr. Szabo mentioned is, okay, if patients then have if there is the provision already allowing patients to be returned to chiropractors after 18 visits, will physicians cooperate? Well, maybe there has to be some teeth into that, to make that more or less mandatory. And, these are just thoughts that I'm having.
Thank you. Do we have any other comments or questions? MLAC members, stakeholders, anybody else? No. Thank you very much for the presentation.
Thank you.
Thank you.
Mr. Chair, the other bill on the agenda for this, sorry, I'm all tongue-tied. From the Society of Physician Associates, they're still working on their draft, so we'll probably carry that over the next meeting so they have everything squared away. So we're done with that one for today. Like I said, there's a couple of workers' compensation bills that we'll talk to the co-chairs about scheduling next time, which is February 3rd. And Teresa just told me there's a whole bunch more House bills that we need to sift through, so there could be something in there. But that's all we have for today, I believe.
Okay. Great. So do we have any other issues or questions or kind of closing comments from MLAC members? Seeing none, I think we can adjourn. Thank you, everyone, for great presentations and participation.
Bye, thank you.
Yep, thank you.
Thank you very much.